Good morning, everyone, and welcome back from the break. My name is Julia Wacloff. I am the Office of Oral Health Chief at the Arizona Department of Health Services. And I'm excited to be here today to moderate our last panel of the Maternal and Infant Mortality Summit, titled Insights to Improving Maternal and Infant Health Outcomes in Arizona Communities. Next slide, please. Over the last 2 days, we have heard quite a bit about the leading risks associated with infant mortality and maternal complications, specifically risks like not receiving prenatal care, conditions that may lead to preterm birth and low birth weight babies, and safe sleep. Since we know improving maternal and infant health outcomes is so complex, we thought we would bring in some additional voices to help us tie together all the information we've heard over the last 2 days and highlight some programs that are working to improve health outcomes for women and infants. We are hoping that each of these insights will help our state achieve health equity and improve health outcomes for Arizona families. Next slide. Now I would like to turn it over to our first speaker, Carol Lewis, who is the Assistant Director of the Alpine County Health Department. As a reminder, full bios for all of our speakers are located in the Whova app if you would like to learn more about those you hear from today. We are also going to hold all questions to the end of the session, but feel free to type them into the Q&A section on the Zoom app at any point. Welcome, Carol.
Thank you. I'm going to go ahead and start my screen right now. It says it's disabled for me to share.
Give us 1 second, Carol. We'll work on that real quick.
Thank you.
Okay.
All set. You should be able to do it now.
Okay. Can everybody see that?
I think it's showing us the folder with the files rather than the slides. I don't know if you just can switch your screens. If you go to the top, if you push your cursor all the way to the top, there should be view options or something like that, and there should be switch presenter screens.
I'm having difficulty. Let's see. I apologize.
Oh, that's okay. You can also just minimize the file folder that says desktop with all those files, and then when you're even just stop sharing, and then when you share again, you can maybe select the PowerPoint.
Okay. Now, can you see it?
Yes, perfect. So if you
Okay. Sorry about that, everyone.
Okay, and if you press, yeah, start from, there you go. Set up slideshow or start from beginning. Perfect. It looks great.
Thank you. So as I was, my name is Carol Lewis, and I work with the Alpine County Community Health Services. I want to give you a glimpse of our county before I go into more of what is happening here. These are some pictures. Our county is pretty huge. We go all the way north to Ashbrook and Seligman. We go west to Baghdad. We have some of Sedona in our county, and the Verde Valley is another big part of our county. Some statistics here. We are an older county as far as the age here. A lot of people come here to retire. So our median age is 54.7. 15% of the population live in poverty. 1 in 4 children, about 25%, live in poverty. In 2017, Yavapai County had an infant mortality of 6.1 deaths per 1,000 live births that failed to meet the Healthy People 2020 target, and no more than 6.0 deaths, 1,000 live births, and higher than the state. which is 5.6 deaths per 1,000 live births. And like I said, we're a pretty large county, which if you put Rhode Island, Delaware, and Connecticut and the District Columbia combined would make the size of our county. So we have a lot of area to cover. Some of our health outcomes for Yavapai County, thanks to First Things First for all these statistics, but in 2016 to 2017, the rate of neonatal abstinence syndrome, which is opioid addicted babies in Yavapai County, was 6.8 per 1,000 live births, and the state rate is 7.4 per 1,000 live births. The number of children 0 to 2 receiving services from the Division of Developmental Disabilities rose steadily at the region and state levels between 2015 and 2018. In that time frame in Yavapai County, the number of children ages 0 to 2 receiving DDD services increased by 45%, whereas the number of children 3 to 5 in the region receiving DDD services has remained the same. Yavapai County has a relatively high proportion of births to mothers who use tobacco while pregnant. 13% of births in 2017 in the region were to mothers who reported using tobacco, compared to only 4.7% statewide, and a Healthy People 2020 target of no more than 1.4%. And as other rural communities, vaping is also very high in our county. What are some of the risks in Yavapai County? In 2017, Yavapai County had an infant mortality, 6.1 deaths per 1,000 live births. That failed to meet the Healthy People 2020 target, no more than 6.0 deaths per 1,000 live births, and higher than the state 5.6 deaths over 1,000 live births. Between 2015 and 2017, there were 148 emergency room visits and 42 inpatient hospitalizations for asthma for young children ages birth to 5 years, excluding newborns in the county. The average length of stay for asthma hospitalizations was 2.6 days, was higher for the county than the state at 1.9 days. Between 2015 and 2017, there were 56 deaths of children in our county, the majority of which 39 were young children ages birth to 4. And the majority of deaths of children ages birth to 17 in the region were due to natural causes, followed by unintentional or accidental deaths and suicide. And we're seeing a higher amount of youth deaths associated with opioid overdose. And so that's something that is more recent that we're seeing a lot of. So that was a gloom. Let's see what's going well in Yavapai County. Yavapai County has a higher rate of prenatal care than Arizona as a whole in 2017, with a small proportion of births to mothers who had no prenatal care at all, 1%, no prenatal care in the first trimester, 22.4%, and fewer than 5 visits if they did have prenatal care, 4%, compared to the state rates, which were 3, 26.4, and 8 respectively. Yavapai County was close to meeting the Healthy People 2020 target of at least 77.9% of births to mothers receiving prenatal care in the first trimester. And I attributed that to our amazing Health Start workers in our community that get those women immediately into prenatal care in their visits, and also working closely. One thing about Yavapai County is we work closely with our partners. We work closely with our hospital, that is a plus with this county. The proportion of babies born at low birth weight in Yavapai County, 7.5%, was equal to that across the state at 7.5% in 2017. The region met the Healthy People 2020 target of no more than 7.8%. For rates of preterm birth, the Yavapai region, 8.3%, along with the county, 8.5%, and state, 9.3%. Met the Healthy People 2020 target of no more than 9.4% of births before 37 weeks gestation. One of the things, like I said, we work closely. Our hospital, Yavapai Regional Medical Center, is transitioning to Dignity Health here in our Tri-City area. And they have started implementing a SHIFT program, which is Safe, Healthy Infants, Families Thrive. I'm sure many of you have already heard of this, but it's essentially about implementing a universal screening for substance use disorder for pregnant women and building a support team of providers. It's a one-page validated tool for universal screening of pregnant women and up to 6 weeks postpartum. It screens for substance use disorder, depression, and on average, it only takes 90 seconds to conduct, 3 to 5 minutes for brief intervention. And the current grant that Dignity Health has is going to help with provide trainings and tools for our community. There's more information in case you're interested in learning more about this program, but I think it's going to help us tremendously identify our at-risk pregnant women and be able to provide them services at an early stage. How are we addressing the outcomes? YCCHS addressed safe sleep by bringing in key partners to the discussion. ADHS was involved, our Dignity Health, Alpine County Medical Examiners, WIC, Health Start, NICU program, and Vital Records. We had our first meeting on June 28th with 20 attendees. Since the meeting, Yavapai County Vital Records Department is including with every birth certificate information on safe sleep that was provided by ADHS. Future meetings to include, I'm thinking big. I really want to see an annual conference to address maternal and child outcomes in the Alpine County and safe sleep. We have a long ways to go with this, and it was great to hear the following speakers before this, and it was amazing to hear the ideas, and this is a great place to share those ideas. Yavapai County Community Health Services is also working to include more information on maternal child health outcomes at our community health improvement plan meetings and also in my sidewalk dashboards. Achieving health equity for Yavapai County families. Some of the things that we see is addressing the issue towards health equity is transportation. Many of our residents in rural areas lack access to treatment due to lack of public transportation and distance to medical services. This is common in a lot of rural areas. We don't even have transportation between Prescott and Prescott Valley, which is only about 12 miles away, for people to get back and forth. We don't have any public transportation. And also the lack of specialty physicians is a big one. I mean, many of our families have to travel down to the valley if they want any type of specialty physicians. So hopefully that's going to change with Dignity Health coming into the area, but it's still a challenge for when we're thinking of those rural families. And I just want to do a shout out to our Yavapai County Community Health Services, our NICP and Health Start programs. And these are just some stories. I love stories. I think stories is what we need to hear more of what our programs are doing. And I know a lot of this isn't based on maybe the infant itself, but it's based on the family unit. So one of our public health nurses visits a client whose wife was killed in an accident very shortly after the baby was born. A first-time father contacted her right away, and she helped him get formula and has been a resource to dad for baby's health and development for over almost 2 years. A Health Start worker helped a mom apply to a Lions Club for financial assistance so she could have eye surgery. And she also helped another mom apply to the Lions Club to get eye surgery for her teenager. And those are the special thanks to our 2 nurses and also our Health Start workers on there. A special thank you to First Things First. Like I said, there's a link here that you can go into to read more about the report that they put together, but it's very comprehensive. And I would like to end by my contact information and sharing a picture of my 2 grandkids. Paisley entered kindergarten and Tristan entered preschool at the age of 3. So, and one of my quotes that I really like is, anyone who does anything to help a child is a hero to me. So thank you to everybody that has impacted these families in so many ways. So my gratitude to all of you. So call me if you have any questions.
Thank you very much, Carol, for opening up this discussion by describing how your team at the Yavapai County Community Health Services is working with families to improve maternal and infant health outcomes. Next, I would like to introduce Meloney Baty, who is the director of South Phoenix Healthy Start, which is a community-based infant mortality reduction program located in South Phoenix. Welcome, Melanie.
Thank you. for the introduction, and thank you for the invitation to discuss our program. I just want to check in. Can everybody hear me okay?
Yes, we can hear you. Great.
Great. Okay, and then are my slides coming up?
Carol, do you mind stopping to share your screen, and then Dave will share your slides for you, Melanie?
Thank you.
I'm having a problem. I don't even see my screen anymore.
We're looking at, or if you come back to Zoom.
I did go back to Zoom.
Back to Zoom. Oh, there you go. So I can see it kind of hovering over there. It should be a red little bar that says stop share.
I did push that one.
Do you mind pushing it one more time? Let's see if it.
I don't even see it on my screen at this point.
Let's see, Dave, can you override?
Working on it.
Sorry about that, everyone.
No, that's okay.
Yeah, all I see is people's names. I don't even see the.
Let's see. Sometimes if you put your cursor all the way to the top, Carol, something will drop down for you just all the way to the top of your screen. There you go.
Oh, there it is. Okay.
Nice.
Let me see.
So we are set, Carol. Dave's got his slides up. Thanks so much for your help.
All right. Are we ready for me to proceed, Clark?
Yes, everything looks good. Thank you.
Thank you. Okay, again, thank you to everyone who has invited us here today to talk about infant mortality and maternal health. So just a little bit of information. My contact information is on the screen. So Dave, if you could go ahead and change the slide. Thank you. Healthy Start received its first funding as a nonprofit. And then in 1998, the program transitioned to Maricopa County Public Health Department. So we've been providing culturally appropriate services in the South Phoenix community for over 20 years. Our funding comes from two major sources. The first is a federal grant for Healthy Start services, and that's infant reduction, and then a state grant for maternal mortality innovation grant, which is for maternal mortality. Next slide. So I wanted to kind of give some context to the infant mortality rate here in the South Phoenix area. So nationally, the infant mortality rate is about 5.7. And those numbers go up and down, maybe a point or two, depending on what article you're looking at. In Arizona, the infant mortality rate is about 5.7. In Maricopa County, it's about 5.8. But then when you look at the South Phoenix area, we're at about 12.3 as a rate. So there definitely is an issue, and services are needed in the South Phoenix area. Next slide, please. As our health educator and doula coordinator mentioned in our last presentation, we do service about 32 different zip codes, and this is the areas that we service within Maricopa County. Next slide, please. So we were asked a series of questions, and one of the questions that we were asked is, how does South Phoenix Healthy Start uniquely serve our community? And I think we have to start with National Healthy Start and what is important to them and how they recognize a woman in the maternal health field, because it's a little different than most programs recognize women. So of course, there is a woman, and she is then having a baby with a father, which then creates a community around her. And so Healthy Start looks at each of those areas and has put funding towards each of those areas. So we work with women to reduce maternal mortality. We're working with children to reduce infant mortality. And then we're working with fathers and significant others to work on the health and well-being of fathers and boys. So we're looking even into preconception health, I'm sorry, there we go. Okay, and then we're looking at the community in which that woman lives in. And that's a huge part of social determinants, but it also looks at resources within our community, policies that need to be advocated for within that woman's community, and then community activism that the woman herself can do within the area that she lives in. Next slide, please. So the question here was, what recommendations do you have for the other organizations to duplicate family-centered model? So I'm gonna just kind of go through the services that we provide within our program, which we have kind of embedded in our community and is working well just as a structure, as a program structure. So we have case management, and then we have a medical care coordinator. Those positions are all under our case management. They provide home visiting services, health education, comprehensive risk assessments, health assessments, and referrals to community resources. As well, our care coordinator is located within a medical clinic and does follow-up appointments for mother, baby, and for father. We have on our staff one supervisor for our female clientele, one supervisor for our male clientels. And then we've even broken it down into, we have two case managers that service the community for females, one that works in Estrella Jail, and then one that's on our medical team. And for our males, we have one case manager who services our community. We also have a health education team. They do about 20 different classes throughout the community, and then for our participants. So they service participants, staff, and community. Participant classes are example of those would be something like childbirth class or becoming a mom. For our staff, they do things like mandatory reporting and engaging families in home visiting. And then for community, they do safe sleep classes, car seat classes, and historical trauma related to ACEs. And I have one female and one male health educator on our team. Our medical team consists of one family nurse practitioner, so she can see mom, dad, and baby. And then we have contracted behavioral health services, and they do individual and group services. Can you go to the next slide, please? Great. Our outreach team looks at the awareness of our program in the community, marketing, and then enrolling. We have two outreach coordinators and one social media coordinator that works on that team. And then we have a CAN coordinator. It's a collective impact model of about 30 different community partners. Our pillars for this year are food sustainability, mass incarceration, and then health and wellness. And I'd like to invite everybody. We have a CAN meeting coming up right after this. And so we want to invite you all to join in our CAN meeting. And I will drop that information into the chat when we're complete with this. And we have one CAN coordinator and then one program evaluator also who does all of our evaluation. Can you go to the next slide, please? Okay, great. We also have a doula program within our division, and we have one doula coordinator. We have 5 prenatal doulas, 3 postnatal doulas, 1 male doula. I think it's important for us to also recognize that our doula program and our staff reflects the areas that we live in. And then we have a couple of new positions that are coming on board. So if you could go to the next slide. I really wanted to touch on how important it is in building a program for specific communities, how important it is to actually do the work in that community. Community building is hard work. Often it takes years to achieve. You have to invest your time, your money, and you have to be consistent and in it for the long haul. So the first part of building a community program would really be building a staff. Your staff needs to look like the area that you serve. You need to really be willing to go into spaces that might be uncomfortable for them, whether it be mosques, churches, synagogues, whether it be community coalitions that have different political views, neighborhoods that are not perfect. I always tell my staff I can teach a skill, but passion is something that an individual has to have to come into this work. The second thing, as far as building a community program, is to really be vigilant about community mapping. Each month, our outreach coordinators take a zip code and they map that zip code. They understand what organizations, agencies, schools are there. They bring that information back to our case managers. And then it's important to be culturally appropriate. I think one of the most important parts of being a culturally appropriate program is to start off your intake asking questions about what are the cultural norms in your home. Being very vulnerable and saying, I may not understand it, but I don't want to offend anybody. Please let me know what it is that I need to do to come into your home so that we can work together, whether it be, how do I greet everybody? Do I take off my shoes? Do I need to have a head covering? How do I respect the elders living in your home? I think the intake process is really important in that cultural appropriateness. Also, as a practitioner, don't come into a home and dictate what should happen in that household. Respect the life that you haven't lived and that your participant is currently living. So that's a really important part of that. And I think, Dave, you've already gone to the next slide, so I will also. Also navigating your community, make sure that your staff understands who is in their community. Barbershops, coaches in Pop Warner, the WIC workers, clinic staff, daycare workers or directors. That should be a part of your orientation to their job, is so that people understand what's in their community. You also want to make sure that you are reaching out in local and meetings. So every staff member at South Wings Healthy Start has a community meeting that they attend, and they report back what's going on within the community. We also do case reviews. So our team has an opportunity to share new resources for a case manager or for a family that might be struggling. So we're consistently bringing new ideas to the table of how to support people. And again, we have our CAN. Our transportation and advocacy support are also really important in advocating a community. Next slide. So how can we help support women in navigating social determinants? One of the things that Healthy Start does really well is our documentation. And so in our documentation, we have a complete section on social determinants, which covers every social determinant that you can really think about. Our data system makes sure that we are asking questions about how do you feel safe in your community? How close is the local liquor store? How close is your local grocery store? Are you registered to vote? Are you volunteering? So it gives us a well-rounded idea of what a woman is and what her community looks like. Other things, again, knowing that we have male staff that supports the idea of an entire family, not just the woman. I'm sorry, can you go back one slide? Okay, so the slide on social determinants. Okay, I don't see it there, but I'll go ahead and talk about it here. Also things that you need to know about in your community that case managers definitely need to have on hand. Food sustainability, what food banks are near, what community gardens are near, have employment agencies, transportation, and housing that definitely needs to be supported by case managers. Let's talk a little bit about the roles that males have in our program. We had to come up with a philosophy for our program in supporting males as partners in infant development, not just as an afterthought. We wanted to develop their roles as fathers in early care for infants, and then also provide them with community resources. Our current staff is one male case manager, one that works in our jail system, one male case manager that works in the community. We have a health educator, and we are looking for an outreach person to do male support right now. Things that we had to work on as a program to support males, we had to really look at what curriculum we had and what was going to work. We had to look at scheduling for men, and then we had to look at how we were marketing our materials, because they were very women-centered materials to men's. We had to look at our office space as well. We offer several classes for health education through 4 men, specifically a childbirth class, a father engagement class, a daddy and me. We developed family visits and co-parenting classes, job readiness, and child support assistant classes. And then our clinical services, again, we have a nurse practitioner, behavioral health, and then we have a 24/7 dad support group. Can you go to the next slide, please? Okay. So new things that are coming up and how we're supporting health equity. We have a health equity position that is going to be hired very quickly here. And we're going to look at how our clinics in the South area, how we can get them on board with the AIMS bundles. We're creating partnerships with colleges, universities to support internships that really look at social determinants of health. And we're working in conjunction with Maricopa County on equity work that they are already doing. Other things that we are looking at is our midwife or our nurse practitioner providing services, contracted behavioral health services, and then doula services. And then we're working along with, in collaboration with our local agencies, such as mass incarcerations or community gardens. Okay, I think the next slide, please. So I think that's the end of my presentation, and I think we'll come back with some questions and answers a little bit later.
Thank you, Melanie. It was great to hear what you and your team are doing at South Phoenix Healthy Start to help keep infants and families safe. Next, I would like to introduce Casey Crowley, who is a nurse program manager with Chiricahua Community Health Centers, which serves southeastern Arizona. Casey is going to speak about their perinatal telemedicine program. Welcome, Casey.
Hi, good morning. Can you guys hear me okay?
Yes.
All right, I am trying to share my screen. Are you guys seeing the presentation?
Yes, and you're just a little quiet, Casey. I don't know if you can,
Sure,
we can adjust that anyway.
I can try to speak up. I apologize. I've been fighting a little bit of a sore throat this week. So
Sounds much better. Thank you.
yeah. All right. So again, my name is Casey Crowley. I am a registered nurse by training. Along with managing our Chiricahua nursing programs, I oversee our women's health department. I'm going to be talking to you today about how our health center integrated telehealth services in our day-to-day routine, and then specifically for our prenatal telehealth pilot program. Just a little bit about Chiricahua. We are a federally qualified health center, and we're located in the southeast corner of Arizona along the New Mexico border. All right, so I'm going to tell you about the origin of our telemedicine services and the impacts we're seeing on improving access to care for pregnant and postpartum moms and their infants. I'm also going to be telling you how these services impacted our ability to support these families during COVID-19. So really in April 2020 is when COVID-19 hit our Cochise County community, and our health center transitioned to primarily telehealth appointments in a matter of a week. time. How we supported this and supported the families in our community with doing this is we had specific dedicated staff on hand to help with any technical issues that arise, making sure they were able to, download the app, get connected with their providers. Clean spaces were created so we could continue well-child visits and with routine vaccines and developmental screenings, which we all know are important. And this allowed for newborns to continue coming to the clinics while we offered support and guidance for parents. So really mid-year 2020 is when we started looking at our county's infant and maternal mortality rates. We were saddened by the results that we saw. So just from 2015 to 2018 in the Douglas zip code area, there was 1,392 births, of which 40.9% had inadequate or no prenatal care. This was statistically among the worst 10 regions in the state. And we wanted to do something about it. The absence of prenatal care providers combined with the challenges of distance, lack of health insurance, lack of reliable transportation, lack of childcare, consequences of missed work, language barriers has all led to late entrance or absence of prenatal care for a significant number of women in our area. Anecdotally, even the most organized and financially capable Douglas area families were not often able to comply with routine recommendations for complete prenatal care. As a consequence, many newborns have been delivered in area emergency rooms and literally along the highway driving to Zara Vista or Tucson. Our county only has one hospital located in Zara Vista that has the capacity to deliver babies, but they don't have a NICU. And in many cases, women, unless they live in Zara Vista, have to drive an hour or more to see their OB providers and for delivery. So in September 2020, we were lucky enough to receive prenatal pilot telehealth grant through AZDHS. With this funding, we were able to have dedicated staff and provide integrated services to support these women in our Douglas area community. We did partner with TMC OB for these services, and our goal ultimately was to increase compliance with prenatal care and decrease the time of travel, which will save the women time and money and improve outcomes ultimately. So you might be asking, how was your health center able to serve families that might not have great access to computers or phones or internet? So again, we continue to offer technical support. We did support in-person visits for acute and preventative for children under 2. This allowed us to continue with routine well-child visits, offer support for families for acute and sick visits also for these children under 2. And then in-person visits were available per request for all others, so adults and older children also, if telehealth services weren't their preference. We also made equipment available within our health centers, specifically because we provide integrated behavioral health and dietetic services at most appointments. And so we wanted to continue these services even though the patients weren't there in the clinic. So we did provide devices that allow them to connect with these services specifically. So for our prenatal program, all right, we found that offering telehealth prenatal services was a little more difficult because of the hands-on care that's needed, specifically fetal heart tones, labs. With our program, we started as a very small private program. So we wanted to keep it between, 5 to 15 patients at a time. And how we integrated telehealth services specifically for these women was communicating directly with the TMC provider that we were partnering with. So we would bring these women in to our clinic for confirmation of pregnancy and initial exams. We would, make TMC aware and then have a weekly touchdown with them to talk about specific coordination of services, which increased patients' experience if, we're talking directly with the OB provider and know the plan of care. So now I just want to share a few success stories on our prenatal program. We had a mother who needed fetal NST testing on a biweekly basis in the last few weeks of her pregnancy. We were able to provide the NST testing right there in our Douglas clinic, which made for less commuting and increased compliance, and ultimately a successful delivery and a healthy baby, which is exciting. Another story is a patient whose last 3 previous deliveries were actually out of the hospital setting, kind of like I talked about before. The first was en route to the hospital, the second was in an ambulance, and the third was in a hospital parking lot. So we were able to help this mom in our program successfully deliver at TMC Hospital as part of our prenatal services. So that was really great news. And another one I wanted to share is we had a 19-year-old mom with 2 young children and now pregnant with her third. And our program was able to facilitate local prenatal care and thus helping this parent receive the necessary prenatal care that in past pregnancies had been more difficult to obtain because she had to drive all the way, to Zara Vista or Tucson to receive those services. So she was very thankful. All right. Some pros and cons of telehealth and prenatal care. So this just shows the distance. So this is here in Douglas, and to Zara Vista is 55 miles, and all the way to Tucson is 125 miles one way. So we found it valuable to see the patients in our Douglas clinic to visualize and obtain labs, fetal heart tones. Again, we utilize the telehealth portion for integrated behavioral health and dietetic appointments, and we provided this equipment in the clinic. So this was for our prenatal care as well as our other patients. So the weekly touchdowns with the TMC provider regarding plan of care for these patients, we found to be very valuable. And overall, this increased patient compliance with care and following recommendations and guidelines. Lastly, I just wanted to share some insights on the work that TerraCal is doing to help achieve health equity for families we serve. So after describing our prenatal program in a broad sense and sharing some success stories, and our overall goal is health equity. So we strive to see the reduction in the need to travel for prenatal care, regardless of socioeconomic or insurance status. We strive for the reduction of fear and concerns by facilitating prenatal care by a culturally competent and bilingual team in the region's trusted federally qualified health center, such as ourselves. Reduction in overall expenses associated with prenatal care and financial assistance for women who are uninsured or underinsured. or in otherwise need of help. So we do have a specific sliding fee program, which also included these prenatal labs. And we also help with any of the costs that, you know, these families weren't able to cover. We did assist with that. And then our goal is ability to provide care for mothers prenatal and postpartum needs, along with our pediatric centers being able to provide care for their infants once born. And then we have an integrated team approach so they can feel comfortable, you know, first coming into the clinic for their prenatal checkup, all the way to, you know, getting close to delivery, meeting our pediatricians, seeing where they're going to bring their baby, kind of meeting the team. So that way it's an easier transition post-delivery. So that is all I have. Thank you very much for having me.
Thank you, Casey. Thank you for sharing more about how you are leveraging telemedicine to improve access to care for women in the Southeast region. And I apologize, I have a train coming by right now, but we'll keep going. Next, I would like to present our final presenter, Alida Montiel, who is the Director of Human Services with the Intertribal Council of Arizona. Alita is going to share with us how ITCA is working with 21 tribes in Arizona to improve maternal and infant health outcomes for Arizona's indigenous populations. Welcome, Alita.
Hi, good afternoon. I did pull up my screen. Do you guys see it? Oh,
Yep, it
wonderful.
looks great.
All
You just
right.
start sharing your slides, and it'll be, or if you just start the presentation, that would be perfect.
All right. Everything is, come on, where are you?
We go to slideshow. Oh, there you go. Right at the top next to, there's like a little screen looking thing next to the full circle arrow. That might get you into full presenter view, or you can just go to slideshow from beginning. There you go. And then all the way to the left.
All right.
Perfect. Looks great.
For some reason, the little bar thing was in the way and I had to move it down. Okay.
Totally works. Thank you.
All right. I'm from the Intertribal Council of Arizona. My name's Alida Montiel. I'm a member of the Pascua Yaqui tribe, and I'm the Health and Human Services Director here at Intertribal Council of Arizona. Oh, it's not moving. Geez. Hello.
Might just, if you try an arrow, maybe.
Yeah, I am. Oh, here we
Oh,
go.
there we go.
It was a little slow.
Yeah.
So, okay, so the Intertribal Council of Arizona was established in 1952 during the termination era. If you've had a course in tribal history, you'll know about the termination era. And that's when the federal government was planning to end a treaty relationship with tribal nations and begin to treat tribes as part of county governments. So that's when ITCA was formed. And then in 1975, we developed a nonprofit organization in order to have resources for tribal nations. Our board of directors are the elected tribal leaders from the 21 tribes in Arizona. Navajo Nation is not officially a member, but they are on all of our work groups. So project areas include Health and Human Services, the Indian Health Service and BIA, annual budget formulation, senior services, epidemiology, WIC and maternal health innovation, environmental issues, education, cultural resources, water policy, water sanitation systems, and tribal incident command support, which was very active during COVID-19, and our Native Voter Initiative. So I'm going to really focus more on tribal cultural considerations in terms of improving maternal and infant health outcomes in Arizona. So acknowledgement and acceptance of these practices by valued by tribal nations could be honored across all medical and community health programs settings. Specific guidance from traditional practitioners, elders, and indigenous birth workers is possible for community organizations or providers serving American Indian, Alaska Native women and their infants. So we also have, of course, American Indian tribes in Arizona, the 21 tribes plus many other tribes. And then Alaska Native women also live in, and families live in our state. So insights on helping to achieve health equity for our families, including long-standing traditional practices that were based on mind, body, spiritual wellness, and balance with the environment. So the acceptance of these practices is already incorporated by several IHS tribal, urban Indian health programs, and by some access managed care providers. At the present time, traditional healing is not yet covered by Medicaid, but services arranged and expenses of the practitioner are known to be arranged intermittently via other resources, such as block grant funding. Access did submit a traditional healing waiver as part of the renewal packet for our Section 1115 demonstration, which is our Medicaid program in Arizona and how the Medicaid program is operated. So this is a resubmission of traditional healing as part of a covered service. So we haven't yet received the official notification whether or not traditional healing is now considered a covered service. I just wanted to show you a map of where the tribal facilities and the IHS facilities are located. As you can see at the northern tier of the state, that is outlined there is the Navajo Area Indian Health Service. And I've listed the inpatient and the outpatient locations. The central part of the map is called the Phoenix Area Indian Health Service. And the inpatient facilities are the Phoenix Indian Medical Center, the White River Hospital, and the Huaga Memorial Hospital in Gila River. And then I've listed the outpatient facilities. And then down at the bottom of the state, there are Tucson Area Indian Health Service, and there's the Sells Indian Hospital, and then outpatient facilities at the Pasco Yaqui tribe. And also they have locations in Guadalupe. And Tohono O'odham Nation has different locations there. You can see at the bottom of the state of the map. But I basically wanted to note to you where our facilities are at, so you have an idea in terms of like what our last speaker spoke about in terms of the distance to the urban locations where you might find more specialty care. So I wanted to have you have a perspective of our tribal communities and where they're located. And these are the reservations that are outlined there in a tan color. So aligning OBGYN and our traditional practices. So this is just what I would suggest, what you can see kind of across the board in terms of best practice, of course, would be labor support services, family-centered at low risk, and full-service birthing centers. And of course, birthing options available, birthing ball, walking, fetal monitoring, hydrotherapy for comfort, non-medicinal pain control, 24-hour anesthesia consults, lactation support that's extensive. And each IHS and tribal facility that provides full or low risk obstetric services are well equipped and staffed with trained and experienced providers. So in terms of what could be considered a traditional and culturally supportive service, and the pregnant family would seek traditional services on their own, or they could do that through the Indian Health Service, tribe, or urban provider. We call that an ITU, or an access plan throughout prenatal and perinatal care. And that coordination of this care is supported. And that a pregnant family incorporates traditional practices in their labor and delivery plan, and that those practices are honored. And that protocols permit feathers in the birthing room, tobacco ties, medicine bundles in the birthing suite or in the labor and delivery room. And another practice could be that a family member conducts the first washing as a water blessing, protection prayers and songs, and maybe herbal medicinal teas that promote and support labor. It's stalled again, I'm sorry. Did it move to the next slide?
Not yet, but I'm gonna pull up the slides just in case it continues to stall. Then I can share my screen instead, but hopefully it'll update in the meantime.
Okay, should I stop share?
Give me just a second. Let me see what slide you're on so I can start. Okay, yep, if you want to stop sharing, I've got it. I've got yours up.
Thank you, Clark.
Yeah, let me get this started. Nope. Oh, I see what you mean about this being stuck under here. Give me just a second. Okay, that was the one you just finished, right?
Yes, it is. All right, so what I wanted to also talk about, because in this conference, you have reviewed data on American Indian maternal and infant issues. And so I just want to mention that recently the Indian Health Service amended their policy manual, and they are addressing the rate of maternal mortality that's no longer appears to be decreasing for American Indian Alaska Native. So it appears to be no longer decreasing. And that the general American Indian Alaska Native maternal mortality rate is above the US all races mortality rates. So their new policy states that they will provide the highest possible technical level obstetric care to our mothers in line with the current American College of Obstetricians and Gynecologists and Joint Commission on Accreditation of Healthcare Organizations recommendations and standards with respect to emergency cesarean delivery, full service, and low risk obstetric services. So they are attempting to address these issues as a result of the that the rates of mortality do not appear to be decreasing. Next. So what IHS is doing is they are establishing a multidisciplinary maternal mortality review committee and they'll conduct thorough and timely review of all maternal deaths occurring in IHS or tribal facilities, referral facilities, and other healthcare settings. The written comments and recorded discussions of the MMRC will be retained in a locked, confidential quality assurance file in the headquarters office of the MCH coordinator, and they'll follow all Privacy Act requirements. Next. So one of the issues that Intertribal Council became aware of is the currently indefinite labor and delivery closure at the Phoenix Indian Medical Center. That happened about the end of September 2020, and mothers were being transferred to other hospitals, and patients apprised the Intertribal Council that they were concerned that if they were not eligible for Medicaid or our specialty coverage, that would be difficult for them to pay their bills for labor and delivery services outside of the Indian Health Service. So our director of the Indian Health Service, that's at the Phoenix area IHS, met with tribal leaders in December 2020 to discuss their concerns. He indicated it would be a temporary closure and that maintenance needs had to be assessed. And they apprised the tribal leaders that there were no patient deaths, no injuries or lawsuits. That was what caused the closure to happen for labor and delivery at the Phoenix Indian Medical Center. Next. So another issue that the tribal leaders focus on, and that's in my area of work, is budget formulation and tribal consultation. We are trying to seek funding for all of our projects through the United States Congress for the healthcare facility construction priority list. If you've been around Indian Health Service for a while, whether you're at Navajo area, Phoenix area, or Tucson area IHS, you know about this priority list, and that the Phoenix Indian Medical Center has been on that priority list for many years. Also, another facility that's on that priority list where they do low-risk deliveries is the White River Hospital at the White Mountain Apache Tribe. There are some other labor and delivery services that are still up and running, of course, at the Navajo Nation. So just to give you an idea, to fully replace the Phoenix Indian Medical Center, and that's about a $670 million project that will take many years to phase in construction. But there's also the replacement of White River and even the Gallup, New Mexico facility, which is another medical center serving tribal nations here in the Southwest. So we're also, what the tribes also said was, we recommend these funds to the US Congress because that's where we get our funding for the Indian Health Service system. But we also look at what these facilities need in terms of what we call the M&I line item, maintenance and maintenance services. And so there's a huge backlog right now in the US Congress that I wanted to mention, just for maintenance and investment in that, just to keep our facilities operating so that we can get fully back operating in terms of the Phoenix Indian Medical Center. Where I know Indian Health Service is seeking the resources specifically for the Phoenix Indian Medical Center, and we hope that those come through. I was apprised recently that some of the surgical suites have already been renovated. So next. So just we want to continue to raise our voice, our stories, and our support for the Indian healthcare system. and especially for maternal and infant and child care, which is, you know, for us, it involves not only state resources, Medicaid, but also congressional resources for to support our system. And that's my presentation.
Thank you, Alita. And thank you again to all of our panelists for pulling together the entire summit and providing specific examples on how programs are addressing the risks that we are seeing in the perinatal periods of risk analysis, while also navigating the unique barriers that communities in our state face. Now we're going to transition to the QA portion with these panelists, and I encourage the panelists to turn your cameras on and be ready with your mics. And I saw several great questions come in, so we'll just start in order. The first question for Carol. Yavapai County has a lot of promising work going on. Do you have any advice for other counties that might be smaller and more rural in trying to move the needle on maternal and infant health with limited resources? And where is the best place to start?
I would start with looking at community partners, organizations around you that have the same goals that you have. Interesting enough, the Safe Sleep came from our medical examiner's office. We had approximately 3 to 4 deaths due to unsafe sleep practices between January and June. So that's a lot for our county. And so getting those key partners, looking outside the box for those key partners. So, you know, reach out to your medical examiner's office and just, you know, find out your local pediatricians or obstetricians, just finding those key partners and starting from there.
Great, thank you, Carol. Now a question for Melanie. Our program has consistently had difficulty connecting with the religious community. How did you begin getting involved with these communities? How did you approach them?
Yeah, thank you for the question. Our outreach team has kind of a protocol that they go through. So the first step is we drop flyers about our program. The second step is that we then set up meetings with whatever agency, church or religious agency that is there. The third step is that I meet with whoever the head of the religious organization is, and then we talk about, is there some type of collaboration that we can do? So we kind of have a protocol for our outreach team, and that's one of the ways that we have been able to start working with faith-based organizations.
Great, that's great information. Thanks, Melanie. Question for Casey. For telehealth, did you have RNs or medical assistants monitor blood pressure values sent in by patients? And if so, did you try to bill for this monitoring under provider 99454, 99453, and or 99457, sorry. And did you get reimbursed?
So we did a couple different things because, you know, we had that rapid transition into telehealth. If patients could take their blood pressure at home with a cuff, then we would just enter that to the notes that the provider was seeing them, that it was patient reported. How another thing that we tried was if a patient needed labs, we would get their blood pressure while they were in our lab area. And then be able to note those in the chart and make the provider aware. We didn't specifically code for the blood pressure monitoring. There is, you know, a recent grant that came out through HRSA for remote blood pressure monitoring. And so our health center is working towards that and those services and tying in, you know, pregnant women and what that would look like, but we are not specifically billing those codes.
Thank you, Casey. Now we'll move on to a question for Alita. Is there information regarding maternal mortality and IHS across the national spectrum for IHS? And how does the Arizona IHS compare?
Well, I know that the information is collected in a data system called RPMS, Resource Payment Management. Anyway, it's a system that's been around for a while. The VA also utilizes that system, but we understand the VA is moving away from utilizing RPMS. That's why I just started to use it, because it's a federal data system. And so now that VA is moving away from that data system, some of the tribes have begun to purchase their own programs for data collection, and then they try to adapt it to RPMS. But that's another big issue in our funding priorities, is updating our data system. But I have seen data on the issues that you've addressed in this conference in terms of maternal and infant mortality. I think that's part of the reason, and I don't have the specifics right now. I apologize for that, but I think that's the reason why IHS updated its policy to address these issues and establish its own committee, such as the one they have in the state of Arizona for monitoring. So I'll definitely check on that and follow up. I'd like to get the detail myself.
Great, thank you, Alita.
Hey, Julia, is it
yes.
okay if I just, Alita, is it okay if we promote the ITCA Severe Maternal Morbidity Report that was put out? I just put a link into it, but it does have, it was the 20, I think it might be 2013 to 2015 or something like that, IHS data.
Yeah, and I understand our Intertribal Council of Arizona has a tribal epidemiology center. Now all across the nation, there are 12 epidemiology centers for each region of the IHS. And as you can see, Arizona has 3 IHS regions. So when our Epi Center developed that report, it was also inclusive of Utah and Nevada, because the Phoenix area includes Arizona, Nevada, and Utah. So then we'd have to also get the report for Navajo area, tribal epicenter, and possibly for the tribes in the southern part of state under the Tucson area IHS, although our epicenter covers Tucson area, so we should be fine with our report. So thank you, Clark, for putting that in the chat.
Thank you, Alita. Now we're going to transition back for a question for Melanie. How can we help more families receive home visiting services like those provided in South Phoenix Healthy Start?
Hi, another great question. We have home visiting programs throughout the state. And so if you wanted to find a home visiting site near you, you would look on the Strong Families website, and they have a map that has all the home visiting programs throughout the state. So you can find one that's close to you. If you are located within the 32 zip codes, I invite you to have South Phoenix Healthy Start as your home visiting program. But you can definitely look on the Strong Family site and be able to find any home visiting program in your area.
Thank you, Melanie. We have a lot of great questions, and I think we're only going to have time for one more. But this question is for Casey. What has been the biggest lesson learned in trying to deliver prenatal care via telemedicine?
So the biggest lesson, really, we partnered with TMC, which are out of Tucson and Sierra Vista. And the women actually wanted to be seen in our clinic versus via telehealth. So we would bring them into, our clinic to be seen. They didn't really want to be seen over telehealth. Again, where we tied in the telehealth was, our provider and our team, our nurse and MA, speaking with the provider from TNC to coordinate the care. So the biggest thing is just the women in our community, they wanted to come in for the care into our clinic.
Thank you. Thank you, Casey. So thank you again to all of the great presentations that we got to hear at the last session of the summit. And also for all of the great questions. We had a lot of good questions come in and it was difficult to cover all of them. So hopefully you can connect with each other at a later time. Now I would like to turn it back to Laura Bellucci, the Deputy Chief of the Bureau of Women and Children's Health, to close out the day for us. Thank you.